Having said that, let us now get to the real meat of the matter. Acetylcholine has been blamed as a culprit in Alzheimer's disease and other forms of dementia. It is very important for learning, memory, attention. What acetylcholine does, it allows the nerve impulse to be intensified at the synaptic cleft. That way, it can increase or decrease the strength of the impulse as it goes to the postsynaptic membrane. This is referred to as synaptic plasticity. It is very important when you listen to very interesting reggae music and you like what Beenie Man is saying, you have more acetylcholine being released, and you tend to remember the song. As when we have someone else singing, you're not that interested, so less acetylcholine, so less stimulation of the nerve. So this is a brain distribution of acetylcholine normally. In persons with Alzheimer's disease, it's significantly reduced. Acetylcholine from nucleus basalis, amply represented all over the brain, reduced significantly in Alzheimer's disease. So there really is very little doubt that acetylcholine deficit exists in Alzheimer's disease and other forms of dementia, and therefore it is a legitimate target for our attention. But what about serotonin? Serotonin we know is important for various different functions: appetite, sleep, behavior, mood, impulsivity, sexual performance, and so on. Is serotonin affected in dementia? This is the normal distribution of serotonin in the normal brain. Dorsal, caudal, Raphe nuclei produces enough serotonin which is amply distributed throughout the brain. What we know from postmortem studies is that there is reduced serotonin representation in persons with Alzheimer's disease. There's reduced serotonin and its metabolites in the brain and in the CSF of persons with Alzheimer's disease. And the studies are numerous to point to a reduction in the level of serotonin in dementia. In Alzheimer's disease, the serotonin pathways are significantly reduced compared to normal elderly. This is a normal elderly. This is the serotonin distribution in Alzheimer's disease. So there's little doubt in my mind that serotonin deficit also is present in persons with dementia. Are we targeting this deficit? There's dopamine, another neurotransmitter, which is important for memory, attention, reward, gratification, learning. Is dopamine affected in dementia? The frontal lobe is extremely dependent on dopamine. So we see from the ventral tegmental area, the frontal lobe gets a significant amount of the supply of dopamine. What do we know? There's a reduction in CSF and brain dopamine metabolites in Alzheimer's disease. There's a reduction in tyrosine hydroxylase, which is the enzymes needed for the formation of dopamine. There's shortage of dopamine receptors. Dopamine is amply represented in the normal brain, especially in the frontal lobe. And you need to pay attention to the frontal lobe is where all the higher functions are based. Executive function, the ability to conceptualize, plan, think through, modify, change data set. All of these are dependent on dopamine. Dopamine is reduced in Alzheimer's disease. What about glutamate? Glutamate is the most prominent neurotransmitter in the body. The concentration of glutamate is about 2,000 times greater than that of serotonin. And yet, in the management of persons with dementia, we tend not to mention glutamate. Glutamate is that neurotransmitter that boosts up. It is the turbocharger of the of the impulse. You know you must listen to what is happening. The lotto draw is going on. There's noise all around you. You have to focus on the numbers that are winning. So your glutamate is what's going to give you that extra push. Of course, if there's too much push, you have the influx of a lot of calcium in the nerve cells, and that can lead to excitotoxicity and cell death. But generally speaking, glutamate is the excitatory neurotransmitter. Is it affected in Alzheimer's disease and other forms of dementia? Let us see. Russell and et al. Showed severe loss of cortical and hippocampal glutamate in Alzheimer's disease. And the studies of glutamate goes on and on and on. Glutamate is now being blamed for a lot of what happens in AIDS dementia complex, Parkinson's disease dementia, and many other forms of dementia. Are we focusing on glutamate when we manage our dementia patients? This is the normal glutamatic pathways, and this is significantly reduced in Alzheimer's disease and other forms of GABA, gamma aminobutyric acid. This is the primary inhibitory neurotransmitter in the brain, occurring in 30 to 40% of all synapses. It reduces anxiety and prevents overstimulation. What happens in Alzheimer's disease and other forms of dementia? Your GABA level is between 200 and 1,000 times greater than serotonin or even acetylcholine. Do we focus on this when we manage our dementia patients? Low et al. Has shown that GABA levels are lower in Alzheimer's disease. GABA receptors are also reduced. If I may go back to glutamate for a minute, we have found that even though glutamate levels are lower in dementia, the CSF glutamate metabolite level is increased. It appears that there's an increased turnover of glutamate in severe dementia, which may be the cause of agitation in many patients. So, back to GABA. Amply distributed in the normal brain, GABA, of course, works in tandem with glutamate to determine the level of excitation that is necessary. All of these neurotransmitters work together in tandem. Norepinephrine, important for motivation, attention, focus, and memory. Amply represented in the normal brain. In Alzheimer's disease, there's reduced CSF norepinephrine levels, reduced brain norepinephrine levels, and also increased metabolites of norepinephrine in the CSF. Again, speaking to an increased turnover of norepinephrine in dementia. So, if we put all of this information together, what we can say, speaking qualitatively and quantitatively, is that acetylcholine levels are down 90% in Alzheimer's disease, and therefore it should be targeted. Serotonin levels are down 50 to 70%. I suspect that this also should be targeted. Norepinephrine levels are down 70%. GABA levels are down 50%. Glutamate levels are down, and dopamine levels are also down. The proper comprehensive management of dementia in these patients should therefore take in consideration all, not some, but all of these deficits. This is a patient with very severe Alzheimer's disease. She exhibits all of these deficits. This is her caregiver. These are the patients and their caregivers that we have to treat on a daily basis. So, if we were to develop an hypothetical treatment model for this patient, a real living patient with Alzheimer's disease, yes, there is acetylcholine deficit. So we must target that deficit. We have the tools in Jamaica. In fact, Palixid is the latest kid on the block. This is generic Aricept. It's now available in 5 and 10 milligrams. 5 milligrams is going to cost you less than $4,000 a month. 10 milligrams is going to cost you under $6,000 a month. And it is available. Aricept, it works. It's still available in Jamaica. Exelon is available in capsules and in patches in Jamaica. So is Reminil or galantamine hydrochloride. There's no reason why we should not be using these drugs. But we have just discussed that there is a serotonin deficit. And therefore, we need to seriously look at the use of SSRIs to address this deficit. Norepinephrine level is low, but there's an increased turnover of norepinephrine, which may explain why these patients tend to get agitated. And so my patients with severe agitation will always be placed on a beta blocker. GABA is the inhibitory neurotransmitter. So your patients who are showing signs of excess agitation, impulsivity, and so on, may be reflecting a low GABA level. You can modulate your GABA levels by the use of mood stabilizers, Tegretol, and so on. Glutamate is now the target of a lot of research. Controlling your glutamate levels by the use of memantine hydrochloride reduces the rate of decline of all types of dementia. So when you have a patient who is deteriorating very rapidly, this is the drug of choice to reduce the rate of decline. Okay, we have mentioned Alzheimer's disease, but there are 3 other common forms of dementia which we face. Stroke. Stroke is increasingly being targeted not just as a cause of dementia, but as a target for treatment. I want to share this study with you, which looked at acetylcholine deficit in vascular dementia. Patients with vascular dementia and Alzheimer's disease were checked for their level of acetylcholine. And they found that the acetylcholine concentration in persons with Alzheimer's disease was significantly lower than normal. We now know that it's down 90%. In vascular dementia, the acetylcholine concentration was significantly lower than in controls, showing a positive correlation with the dementia severity. But the level was higher than in Alzheimer's disease. And the studies go on and on. In the UK, this MRC study confirmed that in vascular dementia, there's reduction in markers of cholinergic innervation, and also serotonergic and dopaminergic. So what are we seeing? And the studies go on and on. Increasingly, memantine, which focuses on the glutamate, is being used in vascular dementia and is giving excellent results. So what do we know about vascular dementia? Acetylcholine is down, serotonin is down, glutamate is down, GABA, norepinephrine are all down, similar to Alzheimer's disease.